I want to thank Brooke for taking over that part and the complex stuff that she's doing. I see patients like this, and they're just so complicated. I wish, I don't know, most of them can't just go up to Colorado from Phoenix, but that's where they need to go. Anyway, thank you everyone for coming for the Venous session. The faculty is great, and I really appreciate your participation. I was going to talk, where's this thing here, about venous stenting, but how we use IVUS. I think IVUS is underused. For many years, I was fighting everyone to use IVUS, and because it was such a great help to me. But I was very lucky that I had IVUS. But how did I have it? I went and borrowed it from the cardiologists. And then finally at Arizona Heart, we got our own IVUS. So interventional radiologists for the past couple of years, or 20 years, haven't really all had their own IVUS in their cath lab. But I think it's a very important tool if you're going to do venous work. So you can see that a third of the population has a compression, which you can see best with IVUS. I think you can also see it best with a CT scan with contrast, where you don't put arterial contrast necessarily. This one study has venous contrast, but that's what I look at when I get a CT scan, is to see where the arteries are compressing the veins. Venous lesions are certainly different than arterial, and this is a study from a vascular surgeon who I worked with and was one of my fellows in Brazil. It's a good picture showing you how different the arterial vessel is on the inside, even with thrombus. And Dr. Razavi did the first meta-analysis here for the venous stenting, and it was a very important paper for us 10 years ago, over 10 years ago. So my pitch now is to try to avoid migration of stents because it can be fatal. And I've heard of too many situations where it was fatal. Not just an operation to get the stent out, because I've had that happen on my own watch, and that was a horrible experience, and I don't ever want to have it happen again. But to have somebody have a stent lodged in their right atrium and affect their heart so that it's a fatal outcome is pretty serious. And most of these incidences have been happening with stents that are put in dialysis fistula. So just keep that in mind. This is obviously an iliac. To prevent migration, I always try to teach people about how important it is to have the stent oppose the wall and be attached to the wall. It's not just the width of it, but it's also the length of it. And that's not intuitively obvious when you start to be doing stenting. And there's a lot of arrogance among physicians who think, well, I don't need to use an IVUS. You know, it's an $800 catheter, and I can see that if I do a venogram. I can see where it's narrow and where it's not. But the information that you get from IVUS is extremely important in being able to judge where you're going to place the stent. So when I do a venogram, I make marks like that from the top of the IVC down to the inguinal ligament area. And at these certain spots there, we will take an IVUS image. And then we will measure both the diameters on both directions so that we get the information. And I'll show you how I put it on the back table. I used to. I've tried to get the companies to make an algorithm that's part of the IVUS machinery, but it hasn't happened yet. I think it should eventually come to that. Oops. Okay. Well, I'm not sure what I skipped over, but we'll skip that. It was just the study of this woman who is a patient that we studied with her. She had a compression, obviously, and we worked her up with IVUS. But you see, it's not, her venogram is not very impressive. You can barely see where the artery is crossing over the vein. It's a little lighter up top by the bifurcation. It's not very impressive. Here you can see a little bit more. But what I'm trying to illustrate here is that you can do measurements without IVUS if you take the time, because you have to do the LAO, RAO visits and then measure off your fluoro. But it's a very old-fashioned way, and we don't use that. And here is the indicator also that there's a stenosis, because you get a high velocity in your common iliac vein, up to 50 or so, and it can be even higher. And that's an indication that there's a stenosis. But below that is the second indicator, which is non-phasic. Well, it's phasic. It's non-phasic. It's actually a flat line, what we call flat line flow. And that's a sign that there is a stenosis above that level. So those two signs are missed by a lot of ultrasound techs, especially in the ER. When people come for left leg stenosis or swelling or pain, and they don't see the distal common iliac and the femoral vein, they don't pay attention to the velocities and the waveforms. And I think that's something that we haven't taught well enough. So that shows there's a 4 millimeter width up on the common iliac. That's pretty small. And here in a venogram, you can see it's 4 millimeters as well. So besides IVUS, you can get these dimensions, but all of the venograms don't allow for that. The IVUS is much faster and much more reliable. So what I do is I have these measurements and put them down in a like this on paper, and verify it with the IVUS, where you measure from front to back and side to side. And you can see we get the area as well as the dimensions. And all of that is a pattern that shows where you need to put your stent. And there's an area that's quite small, actually 90. So when you go to the thigh level and calf, and you can see this lady had swelling in her left leg, but not too dramatic. Her left leg is larger than the right, so that's why she was complaining. And I've known her for a long time. By now we've done a revision because she was treated a number of years ago. But when you see the IVUS marking or the IVUS measurements, it shows you that the area is smaller on top where it's a compression, and then it gets larger in the mid-iliac, and then it gets a little bit smaller down in the femoral area. But the basic thing that these numbers allow you to do is say, if I'm going to use a 16 millimeter stent, how many times is it going to touch the sidewall? So you can count down if 16 will touch the 5.6, yes, or 18, no. 7.4, yes. You can count down and you can see that at 8 points, 8 out of 12 points, the 16 millimeter stent will touch the sidewall. And that gives you 66%. And that's an important figure, because if you use a 14 millimeter stent, it only touches 7 out of 12, which is a 58% touch figure. And what you want to have is greater than 63% touching the wall. That is a figure that came from physicists working in the lab to figure out it has to touch at least 66% or over 63%, in this way of 66. So a 16 millimeter stent is better than a 14 millimeter stent in this patient because it touches every place like 5.6, 7.4, 9.0, 9.4. So a 16 by 90 was selected for this patient. We haven't had a lot of variation in our ability to choose larger stents, but the 1690 wall stent was used with her. And when you place that, you can see that it even doesn't open its total amount because it's not as strong as it is. It could be. The new stents are stronger, push more. So let's see. Let me get to the, oops. I don't know, I have to skip something. So I want to leave you with the fact that it's really important to be able to count the millimeters so that you know if you're going to use a 14 or a 16 or an 18 stent, that you're going to touch the wall so many times so that you get a percentage that's greater than 63%. That's very simple to do, and if your stent won't touch the wall that much, you have a much greater chance of migration because it's the apposition to the wall that's as important as the width of the stent. It's the length of the stent that counts just as much. And that isn't an obvious fact for most people who are doing venous stenting in the beginning. So that's why I'm teaching this point for this lecture. So I see my time is up, and I'll stop here. Okay, thank you. Thank you very much.